Come on. So,
are we online? Yeah. Good afternoon. I'd like to welcome everybody to this panel meeting of the health and adult social care. My name is Jo Lawson. I'm the chair of the panel. If we can have a round of introductions from the panel members and then the speakers afterwards.
Yeah, Tim Bamford, Councillor for Denbydale.
Alison Munro, Councillor for Almonbury Ward.
Helen Clay, Voluntary Co-optee. Catherine Wormstone, Director of Primary Care from the ICB.
Steve Brennan, Director of Partnership Development from the ICB.
Nicola Goodberry-Keneally, Chief Officer for Community Pharmacy, West Yorkshire.
Tom Strickland, Director of Operations at Calder and Huddersfield Foundation Trust.
Keely Robson, Director of Operations for Mid Yorkshire Trust.
Helen Duke, Director of Operations for Locala.
Hi, I'm Saf Boot. I'm the Head of Service, or one of the Heads of Service in Kirklees Council.
Thank you. And online we've got Councillor Beverly Addy.
Hi, sorry, I put this on now. We're on.
I didn't know if you were actually on mute there, Councillor Addy. It's normally what I do when I'm online there. Is first item on the agenda, are there any apologies?
apologies received for Councillor Firth, Councillor Ryler and Kim Taylor Co-optee.
The minutes of the previous meeting, can I move that those are correct? Thank you. So declarations of interest is I will state that I have a bank contract with CHFT, as I normally do. Are there any other declarations of interest? Is admissions of the public. This meeting will be held in public. Do we have any deputations or petitions?
None received, Chair.
And no public questions.
None received, Chair.
Okay, if we can move on then to the first item, which is community accessing care. Thank you.
Thank you. So thank you for inviting us along this afternoon to talk about a range of subjects related to provision of health services in the community. And you've given us a little bit of a brief, and before the meeting you should have received quite a lengthy data pack that's got sections from all of us who are represented today. Obviously we're not going to run through all however many slides there were in that data pack, but we've got a summary pack just to pull out the key points. So I'll kick off just with a little bit of an introduction and some of the national context, and then I'll pass to some of the members who have accompanied me today. So if we could just move on to the first slide, please, and the next one, and the next one. Thank you. So just in terms of some of the national context, I know we've been presenting to you over a number of years on a range of similar subjects, so some of this might be familiar to some of you, but just really builds on some of the themes that you've asked us to speak about. So we had the fuller stock take in 2022, which feels like a while ago now, which really focused on the emphasis building neighbourhood teams, improving same-day access to urgent care, delivery of proactive care and preventative care, and creating the right national environment to support locally driven change. So some of the things that we typically struggle with around workforce recruitment and retention, retention, estates and data flow. Obviously, since then, we've had a change of government and the newly commissioned Darcy review, which reported back in September, which really pulled out some of those themes and acknowledged that right across the NHS, across different sectors, that we're still struggling with some of those things. But, you know, particularly highlighted, I think, where we've spoken before around access to general practice, impact on waiting lists, and looking at where the vast majority of the NHS budget is spent, and really thinking about how we lock in that shift of care closer to home. So again, some of those themes that you've asked us to speak about today, and particularly thinking about creating models of care around neighbourhoods. So next slide, please. Just as a really quick reminder, in Kirklees, we've got 9 primary care networks, which are groups of general practices, but also with a real strength of other services aligned around those, including community services, local authority, voluntary and pharmacy sectors. And then we've gone on to talk about the embedded roles in PCNs, which when we first came to talk to you, I think we'd got social prescribing link workers and clinical pharmacists, and now there's a huge breadth of workforce that's set up in general practice, and particularly key roles around care coordination and social prescribing link workers, and we've gone on to develop mental health social prescribing link workers as well. They often act as the glue between all of these services and really sort of focus on us working together and working well together. Most of those have regular multidisciplinary team meetings, which are generally wider than just general practice, with a focus on proactive care and anticipatory care plans for certain conditions. And more recently now, we're starting to look at across primary care networks, how can those teams work with other teams to make sure that the patients are getting the right care at the right time. So next slide, please. I think at this point we'll move on to talk about workforce, and I'll pass to Steve.
Thank you, Catherine. So we've got a joint workforce programme across Calderdale and Kirklees. So that involves all the partners in the health and care system. What I've tried to do, just for the benefit of today, is just pull out some of the things that I think are relevant to delivering services in community and helping with the integration of services more generally. So the first one on here is about placement capacity expansion. So there is a lot of work ongoing at the moment across West Yorkshire and across Calderdale and Kirklees around trying to increase placement capacity expansion. That's to help support the training of the future workforce, so when students are coming through university programmes, that they have suitable placements in our employing organisations. And in trying to increase that placement capacity, what we're trying to do is increase the number and range of placements in non-traditional settings. So what I mean by that is the majority of placement opportunities at the moment tend to be in acute settings. So what we're trying to do here is change that, not to reduce the number in acute settings, but to try and find more placement opportunities elsewhere. And to increase the range and number of non-traditional placement types in those traditional settings as well. So what we mean by that is things like rotational placements, hub and spoke arrangements and student-led clinics. And we're also trying to improve the coordination, planning and support infrastructure around that to kind of make it happen in a more coherent way. And in the data pack you had, it's not in this one, so in the data pack you had some specific examples of how that might work, and I'm happy to answer some questions on that. Do you want to do the next slide, Catherine, and I'll come back and do my other ones?
Yeah, so the next one, that's just an expansion of what I've just spoken about, the additional roles reimbursement scheme. So this is the breadth of roles now that we've got in general practice. So you can see there's a whole range of clinical roles, including some of the pharmacy roles that have developed into a little bit of a team within a team now. Physicians associates, paramedics, some of the mental health roles that we've just spoken about, and then a real focus on that personalised care and that care coordination. And then we're starting to see a little bit more around digital transformation roles and general practice assistance as well. Next one, I think this is still roles in primary care, and I think particularly the work of the care coordination to personalised care approach that are embedded within the local authority. But actually what they've been able to do now is demonstrate real impact on numbers of appointments saved, both from a general practice perspective, but also from the perspective of A&E services. So, you know, for a while we thought these roles are really good and they're getting really, really positive feedback from patients, but actually we're able to start to demonstrate now in quantifiable terms just how many appointments that are saving on the wider system.
Okay, so just to talk you through this So we've got the apprenticeship programme that we've established with the University of Huddersfield. The first cohort of this started in September last year, so they've just come to the end of their 12 months actually in the university, and then they've got another 6 months to finish all the various assessments and pieces of work that they need to do. Second cohort has just commenced. One started last week, one started the week before. And the rationale for doing this is, as it's kind of outlined on the slides really, so it supports individuals' learning and development. Their teams and their organisations then get the benefit of the increased learning that these students have gone through. Because it's a very practical and applied course, a lot of the learning takes place in the workplace. So you're kind of getting the benefit of it as you're working through the programme, and then the onward benefit of the kind of increased skill set, knowledge and so on of the individuals on it. It uses the apprenticeship levy, so it's not free, but it is paid for from an existing resource, and some of that was being unused, so it's a helpful way of making sure that we make the best use of that money. And the other bit as well that we've kind of like very explicitly as part of this is we've tried to get people from a range of organisations and backgrounds onto the apprenticeship programmes, because they spend a fair amount of time together over that 12-month period particularly. They're starting to form new working relationships that they otherwise wouldn't have formed, and they're beginning to get an appreciation of other bits of the system by speaking to people on a regular basis who probably in their ordinary daily lives they wouldn't get a chance to bump into. And that is beginning to have some really important benefits now. And when you speak to the students who have gone through it, or the learners, is probably a better way to describe them, when you talk to the learners who've gone through it, those opportunities are as valuable as the kind of official core taught process, if that makes sense. And the other reason that it works really well is we're working with our local university, so it supports the university in what they're trying to achieve as well. Just as a really quick point, when we started this, it was a Kirklees scheme. We extended it to Kirklees and Calderdale fairly quickly, almost as we were launching the first cohort. And this time there's quite a number of colleagues come from the Wakefield bit of the world. So given how all the provider footprints kind of overlap and so on, and how our residents in Kirklees go to more than one kind of provider, that's really helpful actually, because we're all part of the same bigger system. So that's beginning to have some really important benefits now, I think. And I think doing things like that, what we're finding is it's a really helpful way of people appreciating how the system more generally works and helping them get out of just thinking about their own professional background or organisation. So that's part of the reason why we've done this. So.
Okay, thanks. If you can move to the next slide, please.
Yep. Sorry, this one's me as well, isn't it?
No, I think it's me.
No, there was one
Oh,
more.
sorry.
Sorry. So again, just a list of some of the things that we're doing there. So one of the other big emphases we've got in our workforce programme is about staff health and wellbeing. Now, what we don't try and do is do something that individual organisations are already doing themselves. We try and add value to that, and the way in which we do it is by running things that you can't really do on an organisational basis. So the Community Schwartz Rounds is an example of that. It's a space where staff can come together, share stories of their experience of delivering care or working in the health and care system, and support each other with that. We are one of the kind of forerunners of doing that across a community setting rather than just in acute hospitals, so that's been really helpful. We've got a compassionate leadership programme that is proving really popular and really beneficial. Again, that's something that an individual organisation probably wouldn't be able to do sustainably, but doing it across the piece is really helpful. And we've got a bit of a train-the-trainer programme to try and continue to roll that out. The Communities of Practice Network is part of how we're trying to make that an ongoing thing and a sustainable thing. We've done quite a lot of work and continue to do it with, it's called Social Care Innovation Programme on there. That's working with care homes, because one of the things we found quite early on was that staff in care homes aren't able to come out of their workplace to access some of the offers we were putting on. So what we do now is we go to the care homes and do it that way so that they're able to access them as well. And then we do some virtual sessions as well, because again, that's sometimes easier for people to access in the lunch. And what we try and do on purpose is try and make these available to maybe those bits of the system who don't have the in-house capacity quite as much as some of the larger organisations. Because clearly the better we look after our staff, then it's better for the staff, it's better for the patients, and it's better for retention and things like that. So.
Thanks, Steve. Next slide, please. So I think this slide's really helpful, just so that you can familiarise yourself with what's in the Primary Care Access Recovery Plan. So one of the things that you'd asked us to talk about today was access to general practice. So we've been working on this plan for a couple of years now, and you can see the main aims there on the left-hand side around empowering patients, implementing a model of access called modern general practice access, building capacity, and there we talk about some of the multidisciplinary teams we've already touched on, and the aim to try and cut bureaucracy, which is something that we hear all the time from general practice, because that really takes them away from patient-facing duties. So next slide, please. I'll not go through all of these because I know you've got them in your pack, but this is one of the graphs that I do quite like because it summarises the picture over a few years. You know, so if you can see where we've gone since we've started measuring this consistently and nationally, from that sort of amber-coloured line right at the bottom to the purple line, we're partway through the year now. There's always a little bit of a lag in the data, but you can see just how much more capacity we're actually providing. So even though it's called a recovery plan, we've sort of recovered and we're over and above now where we were sort of pre-pandemic, and demand's still going. There's always a bit of seasonal variation that you can see. It always dips a bit in August and December, and generally you can start to see where flu vaccinations and winter vaccinations come in October, but we are consistently above where we were now. So there is an awful lot of capacity being provided, but the demand continues to grow. Next slide, please. I'll not dwell on these next couple, but it's the same sort of information that looks at DNAs, which again I think is something that we've spoken about in this forum previously. And I'm pleased to say that that's sort of stabilised and it's a little bit lower than where it has been, because that's the number that you'd want to come down. And then the next slide, please. Again, face-to-face appointments. I know that's something that we often hear back from patients, and you know, again, we're much higher than we were on that, and obviously a change since pandemic days. Next slide, please. So modern general practice access. So this is often where we're trying to ensure that patients have got an equal footing. So it doesn't matter whether they ring, whether they turn up in person, or whether they've engaged with the practice digitally, that there's a method of sort of prioritising all of that demand and making sure that it's going through the right place at the right time into that really big team of multidisciplinary roles that we've got now. So we've got 43 out of our 64 practices who are working towards that model, and some of the others that are now looking at that and considering when they might want to implement that. So that includes things like care navigation and just making sure that they've got the capacity there to match the demand and understanding that in some detail. Next slide, please. So one of the other aims in the Access Recovery Plan is about patients being able to self-refer. So linked into some of that work around reducing bureaucracy. So can patients access some of those simple services or more straightforward services themselves without needing a GP referral? So that includes things like weight management, community podiatry, wheelchairs, falls. So again, I'll not go through all of those in details, but you can see that we're making good progress in enabling access to a lot of those. And where it isn't quite there yet, there's a plan or there's a procurement underway that should build some of that in. Next slide, please. And then there's an awful lot of emphasis on proving access digitally, and I know that's not suitable for everybody, but for those who it is, there's a lot of work going into improving telephony systems, enabling access to records, because then if you can see your own record, you don't have to ring up the practice and ask them if your results are back, and enabling registration online through NHSnet and through the NHS app. Next slide, please. And then there you can just see how the number of online consultations is steadily growing. So we put a new package in to facilitate this a couple of years ago, and practices are working to enable that where it's suitable for patients. Next slide, please. And then just wanted to reference the GP patient survey. Because although we hear a lot about when access doesn't work, actually some of these results in the survey show where it really does work, and we do pretty well in this survey in comparison to other places in West Yorkshire. Certainly one of our PCNs out in the valleys tends to come quite at the top, and they have done for the last few years. Often that pattern matches to where we know there's variation either in the workforce or in deprivation, but actually all practices and PCNs have worked really hard on their patient survey results, and they generally go back and discuss some of those in their patient reference groups. So I've put the link there if you do want to look in any more detail. Next slide, please. I think that's it from me. I think I'll pass over to Saf and Helen now.
Thank you, Catherine. So the committee will have already heard about some of our good joined-up efforts to bridge the gaps between health and social care outcomes as well as health and social care services. And one of the factors that we wanted to just describe to you all about today was how the model for Home First, which includes reablement, intermediate care services, contributes to dampening some of the pressures across primary care and secondary care services. And part of that is having well-designed and sustainable community capacity in the places that people call home. So this section of the presentation provides an overview of the Kirklees Home First model. It's a model which brings together a set of services, a set of teams and workforce under a model which relieves pressures on NHS partners, which also moderates demand for hospital beds and beds in the community and strengthens our shared ethos of home being the place of choice for to support with recovery, to support with rehabilitation, to support with reablement. Nicola, can I have the next slide, please? So whilst the focus on the slides is very much about reconfiguring pathways, there's also a significant cultural change element to this. And it supports the shift in our ways of working in terms of Home First being a culture, not just a set of services, not just a service model. And with Home First, we want to begin with the assumption at all levels that people can live well with the right wraparound support. They can live well, they can live independently, and they can be supported to live well and independently at home. So the slide you see here is our attempt at describing some of that and the kind of comms and engagement that we are using with people who use those services or patients and the types of options or choices that people would have. And I'll run through some of the detail, or Helen and I will run through some of the details of the services that comprise our Home First model. Next slide, Nicola. Thank you. So following a set of workshops with stakeholders or key stakeholders across the health and care system, including Health Watch, we collectively designed a Home First pathway model in which everyone involved has a shared understanding of the best outcome for the person or the patient. Now in Kirklees there are in excess of 20,000 discharges for adults and older people in a typical year. And in terms of what good looks like, these are the pathways that a typical patient journey would navigate through. And our aspiration very much is about pushing it upstream. So our aspiration is that a larger proportion of people are supported through Pathway Zeros, which are your simple ward-based discharges, but fundamentally Pathway 1, which is very much about support in the home through our joint services that the Council and Locala deliver. Pathway 2A, Pathway 2B are bed-based services in the community. So these are intermediate care beds, which are hosted in Murfield, Ingsgrove House, and also our recovery hub, which is hosted in Moorlands Grange, which is, I forget which ward it is now. It's not Newsom. It's in your ward, Councillor. Netherton, yes, thank you. Forgive me. And then ultimately Pathway 3 is which is where a patient or a person would require more complex care within a bedded setting with 24-hour support. That's where we would hope to support people through a long-term care pathway through a trusted assessment working with partners. Next slide, please. So this is just an example of some of the services that support the entirety of the Home First model. And you can see there, the committee will see there, that there are a range of offers from home without any kind of new support right through to what long-term care looks like. And hopefully the committee can be reassured that it's a partnership offer. No one agency can achieve this in isolation, so it really does require us to work in partnership. And it's very much centred around that ethos of home being the place of choice. We do recognise that some people require more complex care outside of a home-based setting, and this is where the support through our intermediate care bed base and therapy delivered through our Locala teams and care delivered through our council teams is held there. And then, of course, we have our recovery beds, and this is where a patient might require a form of recuperation or recovery outside of a hospital environment. So we have 40 beds that we support through that bed base with an aim of supporting people back to their journey home. And what we see from our performance information that this is already paying dividends. We're seeing almost a 30% increase in the number of discharges into reablement pathways. And 80% of those then are supported to maximise their independence. So that's one outcome that we're really pleased to celebrate. Also within our recovery beds, we are now seeing that that's one consolidated bed base. So for all of our council teams, locala teams and teams across the system, we've brought together a range of beds that we would describe as spot purchase beds across Kirklees into one consolidated environment, one consolidated setting with the right in-reach support, with the right care support. And again, we're seeing some really good outcomes in respect of the patients who are supported through those pathways. And I know Helen wants to talk a little bit more about some of the achievements that we are seeing through this model. Thank you.
Thank you, staff. Next slide, please. So this just summarises some of the achievements since we've really enhanced our home first discharge pathway. So we've got carers that counts, there's up to 35 carers a week within the acute trusts. We've got patients being supported by Age UK and how to get patients home in a safe way of transfer. Like we said, with the Reablement offer, 385 people supported each week from October 2024. So that's an average of 3 days from the referral, which has significantly increased. So we can get people to be in a better setting to help recover from secondary care. I'm not going to go through all the details, but we've improved our work around discharge and that integrated transfer of care team. And I think one thing that does help our success is the really co-location joint working with between social care and health, and taking that holistic approach of making a round approach for that individual who comes out. We've got very good relationship with the acute trusts. So that helps us support rapid discharge. And I think with the pathways, we can make sure that the patients are on the right pathway to meet their individual needs. And where we have to go into, like if they're going to the recovery beds, it's up to 4 weeks, but it might just be a couple of weeks respite to get them home and get them ready to be as independent as they can within that best place for them. We've got trust assessors working, so that supports patients to get into care homes without the delay. We were seeing patients in a hospital bed because of that delay process, but with a trusted assessment model, we can do that more quickly. And then we're looking at the creation of a Kirklees discharge dashboard. We're going to start reviewing that so we can really closely monitor it and making sure it's giving us the right information we need to develop and inform our services. Next slide, please. So in relation to supporting patients to come out in the transfer of care from hospital, we do a lot of work around admission avoidance. So one of our biggest ambitions is to stop people going into hospital in the first place. So whether that is an urgent community response, so making sure we're going to somebody's home, avoid them going into hospital, we will do that. We'll again take that holistic approach. We've got clinicians within there, we've got therapists, we've got social care. So again, we've got that holistic approach to ensure we can keep people out of hospital. We've got the virtual ward, so we are supporting patients who still have an acute need, but we can manage them within the community with oversight from a secondary care consultant. So again, we can have them in a better setting, which does help improve their recovery more quickly. We've got the ITOC team, so what we do with, not just supporting discharge, but we have colleagues from social and health within A&E that prevents any admissions. So if people do go to A&E and that's not the best place for them, we can rapidly get them home and provide that support in the same way as it would be if they'd had an admission in hospital. And again, that's within Reablement. We've got that up to 2 days to get real rapid support around that, can be for up to 6 weeks. And then we've really developed, which isn't on here, around how we transfer care into those planned services. So once they've finished that short rehab and therapy, we can transfer into our community rehab services. And we've improved our transfer of care pathway. So for the patient, it doesn't feel like a reassessment, a discharge and a move on. It's a smooth transfer. So their care plan will just continue their journey throughout. And we're wanting to enhance that further with wider health and care settings. So that's it for us, thank you. So moving on to community pharmacy.
Hiya. So I'm Nicola, I'm Chief Officer for Community Pharmacy West Yorkshire, so I represent all the community pharmacies across West Yorkshire, but today... Oh, is it not working? Is that better? Thank you. Today focusing on Kirklees. So the Primary Care Access Recovery Plan emphasised the changing role of community pharmacy as the gateway to the NHS for many patients. In January we saw the launch of the new Pharmacy First service. That gave the ability for pharmacists to see more patients and offer prescription-only medicine treatments where appropriate to close as many episodes of care as they can without them then having to go on to see an alternative healthcare provider. Next slide, please. Thank you. So we've got 7 clinical common conditions, and these are the patients that we could see within community pharmacy and hopefully offer a treatment. We do inform the GPs what we've carried out, so it's all in their record, and hopefully most of these patients can go home and will be well. And if the treatment didn't improve, if the condition didn't improve, they then do have the opportunity to come back to us, and we would then maybe refer them on to a GP. Next slide, please. So there were just a few updates there in terms of workforce. There's quite a lot changing in community pharmacy at the moment. Foundation pharmacists are going to come out of university from 2026 as independent prescribers. So we need to do quite a bit of work to make sure that those students, as they're transferring from university into practice, find a DPP, which is somebody that's going to support them through their journey. In a prescribing role. They need to do 90 hours with that person, and it has been quite a challenge to find enough DPPs out in general practice and in trust locations that have the capacity to take on pharmacy students. We've then also got the legacy pharmacists like myself that need to figure out a way of how to become independent prescribers if they wish. And again, with the 2026 date looming, that means it's significantly more challenging for those pharmacists that want to go through the prescribing programme in the next few years due to the DPP capacity. Next slide, please. So nationally, community pharmacy is facing a really unprecedented challenge. The financial pressures are really critical. So this page, there's a lot of details on, and a lot of the details can be found through Community Pharmacy England, but just to highlight a few, it is the national picture, and obviously we work to a core national contract, but obviously it does impact local communities based on where the community pharmacies are. So the average pharmacy relies on the NHS for 90% of its income. Core funding's decreased by 30% since 2015, while inflation and costs have spiralled. So the activity has been requested by community pharmacies to support the wider range of patients and conditions, to support other areas of the NHS continues to grow, and that's all for less funding. So many pharmacies are struggling to stay afloat. The Community Pharmacy latest Pressures survey indicated that 1 in 6 pharmacies may close within the next year, which is quite a scary figure. The number of pharmacies open in England now is the lowest since 2008, despite the actual number of prescriptions growing by over 40% and the addition of many clinical services. So Kirklees currently has 98 pharmacies, and that's a reduction in the last 12 months of 2. So just to summarise, really, community pharmacy really does want to be the solution to the NHS, a strong partner in primary care teams to ease the access challenges. However, to remain open and viable, the funding needs to be there so we can continue to play that active role in supporting patients. Thank you. So in terms of stock shortages, this slide hasn't changed much since last year because unfortunately the stock shortages have continued to be a significant challenge. More and more stock shortages are making the process of dispensing prescriptions such a challenge. Community pharmacies are spending hours and hours each week trying to source drugs from multiple locations, and sometimes at prices way above the drug tariff price, and we don't find out until well into the month whether we're going to actually get paid the price that we've had to pay to dispense that drug. There has been a couple of changes this year to the price concession process. One being that there's a little rollover if the price has been agreed towards the end of the month. Some of those prices are continued into the next month, so you can at least plan ahead a little bit. And the other one, that there is a quarterly top-up system if it's found that the drugs you obtained weren't able to be obtained at the drug tariff price. But that only started in April, and we haven't actually seen much evidence yet of that coming into effect fully. Next slide, please. That's it for me, thank you.
Okay, just the last couple of slides around COVID and flu vaccination. So this is becoming more routine now and business as usual that we offer these vaccinations to eligible populations at this time of year. And just really wanted to highlight, within your packs there'll be some of the data that shows how well we did last year, well underway with preparations for this year's campaign. In fact, we've just started on some of this. And if you move on to the next slide, please. This just shows the sort of range of activities that took place last year, and we're really focused on trying to get those vaccinations offered in populations that sometimes might struggle to access in more typical settings. So if you move on to the next one, please. Flu vaccination programs just started, and that last point is one of the ones that I really wanted to highlight, that for this year they've actually advised nationally that we start slightly later. So often the general practice and community pharmacy will be chomping at the bit at some point in September, but I think history's shown us that actually the prevalence of the disease is better timed, or that the vaccine works better if you just start ever so slightly later. So everybody's been raring to go, and in the last week or so now, hopefully, you know, if you're in one of those eligible populations, you should have had your invite, and would encourage you to take that up. So I know I've just been up to the pharmacy up the road, and they're actively vaccinating today. So everybody's, you know, that sort of eligible is being invited and hopefully attending for those. Next slide, please. So there's just some criteria there around eligibility, which are not hugely dissimilar from those that we've had in previous years. Next slide, please. And then just wanted to mention a new campaign this year, which again you might have picked up through some of the media coverage, where we're hoping that this will help prevent quite a few admissions going into this winter. So eligible populations again being invited to attend their general practice for respiratory syncytial virus, so RSV vaccination. Quite challenging for general practice to work out. There's an awful lot of vaccinations at the same time. So again, really aligning the workforce and making sure where they can co-administer these vaccinations, that they do that. And particularly for us, it's a bit of a focus around pregnant ladies and offering them the right vaccinations at the right time. Often that means a little bit more coaching for the lady who might be just wanting to make sure that everything's safe and that, you know, things can be co-administered. So putting quite a lot of effort into that alongside some of our maternity services as well. So I think that might be the last one. That's just describing that that's being offered through general practice, eligible populations between 75 and 79. Next slide, please. That's it. Thank you. I think we're all happy to take questions.
Thank you for some very comprehensive reports there. I've got quite a few questions. It may look like that I'm picking on certain things, but I've done them as I've sort of read through there, and I'm sure the panel also has some questions there. What I would actually say, first of all, it was good to see the data regarding the social prescribers, because you hear about these things and think, oh yeah, that sounds really good, but it's good to have the data to actually see what it's preventing and people going to A&E, coming to the actual GPs. Can you just elaborate on how somebody would get a referral to a social prescriber and for how long the contact would be?
So I think we've got some of the data, as you've said, in your packs, particularly where we've mentioned that it's saving appointments from general practice or from A&E. But I think social prescribing can be accessed in a number of different ways now. But, you know, primarily, you know, if there's any sort of contact with a GP practice and they can pick up on some of those themes where they think actually longer intervention would be beneficial to the patient, then they'll make that referral. But I think, you know, it's becoming far more known and acknowledged that there's a role there. So, you know, patients can often sort of be picked up through other routes as well. We've got a really strong network of community champions in Kirklees. They've done some absolutely fantastic work on a range of different themes. And again, you know, I think there's a lot more awareness now, so patients can get in that way. I'm probably not the expert in terms of the, you know, the details around how long patients will stay on, but I know from some of the stats that the team share, I think that the bit that sticks out for me is that patients can spend much longer with a social prescribing link worker than they might do with a GP who might be pressured for a 10-minute appointment. So, you know, on average they'll be spending sort of more like 45 minutes with a social prescribing link worker, and obviously then be directed into a range of different other services, some of those, you know, more medical, but some of them often into community groups, and that's where it really dovetails well with the voluntary and community sector as well.
Thank you. I have to agree with the community champions, because through the Thornton Lodge Action Group, they have done a whole range of different health issues. They started off with diabetes, we've done breast cancer, bowel screening, and they have literally taken that out to all different sort of areas, into like coffee mornings at schools, and to supermarkets. They've been into actual HRI to do various things like that, and it's actually really good when you actually see sometimes people need things maybe sort of put into them and explained to them by people that they know, that they see every day in the community. And it's, you know, as a healthcare provider, you can actually, I could sort of say, oh, you need to do this. But if so-and-so that you've known for ages is saying, you really need to get that screening done, I think it does actually work really well. Can I invite the panel to ask any questions?
My first question is in relation to admission avoidance, page 71. It was emphasised, you know, that we rapidly get patients home, and I want to know what kind of checks and balances are in place to ensure that patients are not being sent home or discharged when they're actually seriously ill. And I know of someone that this has happened to. So they were actually sent home and they actually had terminal cancer. So, and it wasn't picked up at the hospital. So can you tell me what you're doing about situations where, what sort of checks and balances are you putting in place? Thank you.
Yeah, so obviously if somebody gets into A&E, they are assessed and triaged by secondary care. So, and we have rapid responders that are from social care within there, and we've got colleagues in ourselves. So we will work together. So where we have got an individual identified that they're not at risk, we will do some wraparound support depending on what the needs are at home as well. So for example, if somebody needs some equipment, we can go home and do that assessment at home. So we'll do a full holistic assessment there. So in relation to sort of the experience that you're talking about, we don't know what's happened in that situation, but we do have access with people in, and we do follow-ups as well. So other elements, if someone's identified as being still needing acute care, they could be put onto the virtual ward, but you've got oversight by a consultant, so there will be some diagnostic assessments there or some triage done and further assessment. So it's kind of a wrap-around holistic approach to that. And like I said, I can't comment on what's happened with the individual you're talking about, but from some of the experiences that we've had, it's worked quite well. And even to the extent of if somebody needs to go into a care home setting, we can look at through that trust assessment model to be able to do that. It could mean that someone's in overnight within a hospital, and we'll support like with the frailty wards, etc., to be able to get people through.
Okay, I'm just, it's actually my mum. Right. I went up with her to A&E, and they took her on the ward. Well, they didn't take her on the ward. They took her into like a side room and did a few things with her, and discharged her with anti-sickness tablets. It actually turned out that she had something. She was then diagnosed a few weeks later, but there was nobody nothing was followed up, nothing at all. And to be fair to the people who were on duty, it was very, very busy. So I put it down to the fact that they were all stretched. Mm-hmm. But it's still a really bad experience to have been through that. And for my mum, who was in her 90s, to have gone through that, and they're not checking, they're not doing the proper checks because they're actually all rushing around. So I really felt that, I think this is something that you need to look at.
I don't know if our
Okay.
secondary care colleagues would want to come in on that from an A&E perspective.
Yeah, I mean, it's be the same point really about, I think you're talking about an experience within one of our ED departments at A&E. Yeah. So, so that's, we wouldn't be wanting to do that. So the expectation absolutely is to stratify patients as they come in. We have minors and majors, and then we assess them. So, have you followed up with?
Well, I mean, to be fair to them, the second time I went with her, a few weeks later, because the problem didn't go away, obviously, they were absolutely brilliant, fantastic, and they were amazing. But I think it was just unfortunate that we hit it on a Sunday evening, and they were clearly stretched. It was very, very busy. But it's an elderly person in their 90s, so. It's just, it was just a really not a good experience. And of course, my mum was very ill, so, the symptoms didn't go away. So, so I just wanted to highlight that and just make sure that you have got those checks and balances in place, or enough staff on the wards to deal with the issues when people come in and they're really ill. Thanks. I've got some other questions actually, if I can move on. My next question is in relation to community pharmacies, and I've actually just got to find my notes now, I'm afraid. I wasn't aware of these seven common conditions that pharmacists can treat. Are they well known? Is that advertised? Is it on the pharmacy window so people actually know you can come here and you can come here for these ailments and we can prescribe you or give you the correct medicine? Is that well-known thing?
So when the service was launched in January, the second month the NHS nationally did an advertising campaign. I think from a community pharmacy perspective, we were a little bit disappointed with how flat that was, and we didn't feel like it's necessarily had an ongoing campaign to support it. So patients can access it either by walking into the pharmacy, or we're asking GP practices where they get a patient that falls into one of those clinical conditions to make an electronic referral into community pharmacy so we can see that patient. Now, community pharmacies are obviously individual private businesses, so in the last few weeks we've done a lot of visits to our pharmacies to support them with leaflets to make sure as we go through the flu season we've got little leaflets to give to patients to make sure that they have the ability to walk in for those services, and we're trying to be quite proactive to help our pharmacies. Some of them especially maybe the larger multiples have done the posters, but we're just, as a LPC, we're trying to do some little marketing tools to help the smaller ones, the independently run pharmacies, to think about how they can self-promote that service a little bit as well, because we agree that the outward message has not landed quite as strongly as we would have liked for that.
Okay, thank you. My second question is in relation to, this is another personal experience. However, when I found out that pharmacies were, when I discovered or heard that pharmacists were actually going to be able to deal with, complaints, you could just go in and see them. So I thought, well, I won't waste my doctor's time. I'll go with this complaint. I got a swelling on my elbow, but I went to see them and they said, oh, you need to see your GP. So I made an appointment with my GP and he said, did you go to the pharmacy? So I said, yes. He said, what did you say to them? So I thought, actually, I'm a patient here and you're asking me what have I said to the pharmacist. So again, I shouldn't be being questioned by my doctor what I'd said to my pharmacist. So that was my experience of it. So I just thought, I'll just go to the GP in future. Presumably you've not had any other, you're not getting feedback along those lines, or how are you getting feedback along those lines, or are people finding the system difficult to?
I suppose it depends. So the 7 clinical conditions that we're talking about have specific clinical pathways that the patient almost has to fit into. That means the pharmacist can treat that patient. And obviously we need to put safeguards in place to make sure if it isn't an appropriate treatment, that the patient would get referred to the appropriate place, whether that was A&E or the GP. Now, if the referral comes, if the patient, walks in, we can then fill in a referral back to the GP, and we can add some clinical notes, so the GP then gets an up-to-date picture of what has happened to that patient. That's if it fits the pharmacy first criteria. With anything else, it would just be a verbal handover back to the GP, and unfortunately the IT system yet isn't in place that we've got that.
So if you...
Catherine, did you want to come in?
I think Nicola's probably covered a lot of it. I guess I was just going to do some of that from the GP end, that, you know, they've worked really hard on getting the systems. As you'll know, in the NHS, we've got multiple different IT systems. Sometimes even, you know, general practice might not always be on the same one, but I think there's a lot of work that's gone into trying to ensure that electronic connectivity is working much better between community pharmacy and general practice, so that this information can flow much better. And as Nicola said, obviously, we've started with these 7, prescribed pathways and 7 conditions, but I'm sure because that's still a relatively new thing that's just been introduced this year, they'll be working out, actually, does this work, and is it something that is benefiting the patient, is it benefiting the workload and the skill set of general practice as well as community pharmacy, and then taking a view about whether that expands into other pathways. But certainly whilst we're going through this year, there's been an awful lot of effort in trying to make sure those systems talk to each other, because we know patients get really frustrated with having to tell their story more than once, so hopefully there can be less of that going forward.
Thank you. I mean, to be honest, I didn't see anybody inputting any information into a computer for me. It was just like an over-the-counter thing. Oh, you need to see your GP, but then you got questions at the other end with the GP. So it just seemed that the system wasn't quite perhaps working as well as it should. So I think that's nearly the end of my questions, actually. I just wanted to know, so you, with regards to community pharmacies again, you said 2 have closed, you've lost 2 in the last year. How many have actually gone in the last 3 years? I suspect it's more than 2. And so it's just a question about sustainability in the future of this new service, basically. Perhaps that's an unknown. Depends on funding, presumably, yeah.
We're waiting to have our negotiations nationally with the government at the moment to find out what our new contract will look like. And absolutely, the sustainability of all community pharmacies depends on what that contract looks like. And therefore, all these new services that we're trying to deliver. And I think some of the challenges are the pharmacies that have higher footfall in city centre locations where there's more people, the ones that might be more viable, but then it ends up being some of the rural ones in quieter areas that don't get as many people, and therefore they're sometimes sadly the ones that are unsustainable and close probably in locations where they're needed most.
Catherine, did you want to come back in?
Only just to mention the first part of your question is how many others, because I can just think, we were sat here, I'm pretty sure it was about this time last year, and we'd had a similar conversation. I think we'd lost 2 that year as well, so there's at least 4 that I'm aware of. But I think, like Nicola said, I think that some of the key things that we look at is then how accessible are the other community pharmacies, and have we still got enough provision in Kirklees? And even though we'd lost some of those, and it's really sad, and we wouldn't want to lose any, that there is still really good provision, when we look at that as we come into every bank holiday, as we come into every peak season. So, I think we have still got relatively high numbers of community pharmacies in Kirklees.
Thank you. As somebody who's regularly used the services of the pharmacies round the corner, because it's a lot easier just to nick round and say, what do you think this is I did actually officially use them and actually had no problems. It was all, I did have to see my GP there, but all the information of what been prescribed to me was actually on the screen there. If I can just ask, paramedics, what do they actually do? As in, when they're employed within the PCN, is obviously my view of a paramedic is they're the people that turn up when you dial 999.
Yeah, that's a good question, and I think we've been looking at sort of building on some of the knowledge. And I think in the early days of sort of people looking at those roles, they were thinking about those sort of home visit type approaches and whether they could help. But often, like with the new model that we've described of modern general practice access, I think sometimes with the skill set that they've got, they can work out there's a cohort of patients that can be directed to them first. And I think we've just been looking at piloting with the paramedics working alongside some of the other roles. So again, that it's more of a holistic assessment. Not every practice has got one, I have to say. I don't think we've got, I'm sure we've reported in previous years that when those early roles were introduced, social prescribing link workers and clinical pharmacists, lots and lots of emphasis went on the clinical pharmacist role, which just helped to compensate, some of the things that Nicola's been describing. So it's not quite as extensive or as embedded as some of those roles, but it's becoming increasingly popular for the PCNs to take up. They've just very recently announced another extension of the ARRS scheme, which will include newly qualified GPs. So again, just in terms of building that capacity, but also starting to address some of the challenges that we've talked about with workforce recruitment and retention. And I think that's going to be a really, really popular role for general practice, because we know that there's quite a lot of fairly newly qualified GPs coming out that want to get into something that's a little bit more stable without the whole partnership model. So I think that there's going to be a lot of emphasis on those roles as well.
Thank you. Is there any questions? Councillor Bamford?
Yeah, it's just about around DNAs. We're losing a lot of appointments through DNAs. Just what work are you doing on that going forward, trying to make people aware that, if they're not going to turn up, they should inform their doctors.
Yeah, thank you. I think we did talk about this a couple of years ago and reported back last year. Quite often, you might have seen in your own general practice, if you go in, they'll often put a notice up to say how many hours have been lost to missed appointments. But increasingly, when we talk about sort of digital technology, a lot of practices now will use a system that engages a text message to patients to remind them, particularly if they're long appointments. Some of the nurse appointments where it's not just a 10-minute appointment, we'll be texting the patients the day before just to make sure that they don't forget. And I know sometimes practices will report, patients will ring up on the morning and say, I've got something that's urgent, and they'll be offered an appointment, and they'll sometimes even DNA those. So sometimes it's sort of outside the gift of the practice to tackle that. But, generally, I think certainly none of the practices I'm aware of, sit back on their laurels with this, because they're acutely aware there's a lot of people waiting, so they want to try and minimise that figure around DNAs. Where we try and offer additional appointments into the evening and the weekends now, and sometimes over bank holidays at busy periods, we look specifically at the DNA rates in those clinics to make sure actually how we're offering them at the right time. Are they suitable for patients? Where we've had a little bit more flexibility about what times we offer those appointments, generally you'll tend to find that they'll DNA more first thing, because they've not had a chance to get up or make the phone call. So there's lots of things I think that practices can do to sort of publicise that, but also to try and address it with some of the digital means that they've got now.
Thanks for that. I mean, the older end obviously aren't going to get a text, are they, or use online services. So there might be something we could do there. And on that, your pharmacy. The things that the pharmacy can treat, maybe there's a bit of a trust issue there with the older population who'd rather go and see a doctor. They probably won't take the word of someone in a pharmacy. That might be something else you could work on, just to try and get more people to trust them and not go to the doctors.
Yeah, I think just sort of to expand on that, because I've put the list up now of all the different roles that are available in general practice, and like you say, and it's not always the older patients actually that are not tech savvy. And I know I might have said this before. I've never forget being in a clinic where they'd had a new batch of COVID vaccine delivered, and they were putting the message out, and actually a load of the older patients were the first ones to pick those messages up and come down. So sometimes sometimes I think we probably do some of that generation a disservice. But I think you're right about the model about actually that, you know, they know the GP, they trust the GP, that's the person they want to see. Sometimes they don't understand some of these broader roles. What can paramedics offer? What can the social prescribing link workers do? So I do think there's quite a lot of education, patient education that needs to happen for those roles as well as for community pharmacy. But that's a bit where the modern general practice access model that I spoke about is trying to say that patients should still be able to access, you know, if that's what they want, if they really want a face-to-face appointment and they really want to see that GP, they might have to wait a little bit longer to do it, but really, that, you know, they should still be able to do that if that's a really strong preference.
Helen.
Hi. I just want to echo what Councillor Lawson said about the amount of evidence that's, I know it looks like a lot, but actually it was really helpful to have the practical evidence of changes and difference. So I'm actually going to ask you for more. But really around patient feedback, and so it's wonderful to see sort of the data in terms of what it's helping to reduce or what we can do instead of that. And it was really prompted, that my question was really prompted by the advanced practitioner roles, and that there's kind of two schools of thought or approaches in terms of some people don't, we've all sort of heard it, or anecdotally of, you know, I actually wanted to see a GP and I didn't know I was seeing an advanced practitioner, and so because I've not heard anything that's evidence, it's that sort of thing of, have you been made aware of people's either for or against any of these particular roles, but specifically around the advanced practitioner?
So probably like you, just a little bit in the media, not particularly locally from our own community. But I think nationally they've taken some of that on board about, you know, about what some of these roles are called, you know, so it's really clear to patients whether they're speaking to somebody who's medically qualified and is a general practitioner or is one of these other roles. I know, you know, one of the other bits of feedback that we do often get is with some of these newer roles that might not be quite as embedded, it takes quite a long time from the practice, the employing practice or the employing PCN, to offer the right level of supervision and make sure that, you know, they're appropriately supervised and supported. So I think, you know, that's one thing that's been again fed back nationally. I've not picked that up through any of our sort of local complaints, but you know, I like you've probably seen quite a bit of coverage in the media just to make sure that people are very clear about who they're seeing and whether the condition that they're being seen for is right for that person.
Is it something that sort of, I don't know, Health Watch would look into in terms of, you know, that getting feedback in terms of that? I recognise that it's a big job to get feedback from patients and users of the service, and whether it was something that either doing some spot checks on that, or, you know, I recognise doing it across the whole area isn't feasible.
It's certainly something I could ask about. Health Watch do a really good job, and I think you know, often by the time the feedback comes through Health Watch, often it's the negative stories or the negative experiences that get to them, but they're really good at going out and doing some of that proactive work. I think other than that, it's that kind of feedback that comes back from Health Watch, as in, you know, I really want to see a GP, or, you know, I've known that GP since I was however old, and, you know, I've got a relationship with them. So that's often some of the feedback that comes through. But again, I'd have to go back and check whether there has been anything specific about some of those newer roles, or perhaps ask them if that's something that they could look at.
And I think in terms of, I think we do sort of sometimes dwell on older people and their needs, and that's right that we do. But actually, I think people below that age who don't necessarily go to the GP a lot and not aware of the changes, they will have, you know, they'll just get an appointment because I'm working and I need to go and da-da-da-da-da. So I don't think we should just specifically, it should be across the board of ages, I think, if we're going to look at that. Thank you.
If I can just move on to regarding is Moreland Grange and Ingsgrove, can you just explain what the difference between a recovery bed and an intermediate care bed? Because I was looking and I was thinking, I can't see the difference there.
Yeah, Councillor, I can do that, and it's firmly etched in my memory now that Morelands Grange is in Netherton, not Newsham, because I was thinking about the other care homes. But yes, I think it's about matching the capacity against need. So for intermediate care, and Helen will be able to add to this also, it's where a person has got needs that are more complex and require some kind of therapy input. So that could be through an occupational therapist, could be a physio, there might be some exercise regimes, etc. Really thinking about their mobility, really thinking about the environment they live in and enabling them or optimizing them with the support that they need as part of their journey home. With the recovery beds, this is slightly more nuanced in that we were finding previously that patients were spending far too long than what we wanted as a system in a hospital bed for recuperation, for recovery. Councillor, you were in this committee when I brought some of the considerations around Morelands Grange previously, because the council did want to consider doing something different with Morelands Grange, but we put a business case into the ICB to look at how we take away that burden of patients waiting when their recovery. So they might be medically fit for a discharge, they might need a little bit more recuperation. Rather than doing that within a hospital ward and burdening our NHS partners, can we create a space where we've got the right care and wraparound therapy support? So some of them might need some in-reach therapy, it may not be as intensive, but that setting allows them to have that recovery, that recuperation in a safe environment with the right type of care and support, and then enable them as part of their journey home again.
Thank you. I did assume that it was a bit like Morelands Grange was a bit like what we would call the old convalescence sort of homes. I actually worked on years ago on what was a GP ward, so we used to get all sorts of different patients in, patients that they'd do the surgery but just needed that extra week being sort of looked after before they were coming home. And can I say one thing about having the care plans that continue when they go home, because there's nothing worse than, oh, we're waiting for an assessment, we're telling people the same thing again. But thank you. Are there any further questions? Can I just thank everybody for their reports today? It's been really good, thank you. Okay, if we can then move on to our next item. That's okay, is that okay? Yeah, no, that's absolutely fine. Thank you. If you'd like to give your presentation, thank you.
Sure. So I think it's Calderdale and Huddersfield first. Just next slide, please. It's obviously it's not us, so it's myself. So I'm Tom Strickland, one of the directors of operations, standing in for Johnny, who's the chief operating officer, and my colleague Kelly Robson. She's deputising for Chris Evans. Next slide, please. Next slide. So, yes, a couple of slides here then for Calderdale and Huddersfield. So, in terms of our diagnostic waiting times, there's a national standard that patients are seen within 6 weeks of their referral, and the standard is 95%. So we as a trust are currently meeting that. A couple of our pressure areas and some of these modalities that are under a bit of pressure because of constraints around capacity, neurophysiology. But there's been a lot of remedial work gone in there, and they are back to being under 6 weeks, and echo, which is our heart scans. So currently they're under the 95% standard, but they are on an improving trajectory. So we're hoping that they will continue to recover. Just moving on then, so in terms of what we call waitlist management, so basically how long patients are waiting for their operations. So we've had a real push on this. Nationally, the standard is to get to 65 weeks. It was at the end of March this year. It's just been extended to September this year. So we've managed to get ahead of that, and we're working on eliminating all our 52-week waits. And as of now, we've got, this says 51, it's actually less than that. We're down to 32, I think it is. The majority of these are in ENT, ear, nose, throat. So that's where we have our biggest challenge from a capacity point of view. This last section on the slide, cancelled elective planned procedures, it sounds a bit, it's not very specific. What this is actually around endoscopy. So these are these scopes that are used as a diagnostic procedure, and you can also potentially use them as a treatment as well. What we found is, so we do across our hospitals about 250 per week, and we were finding 2 or 3, so not big numbers, but were being cancelled on the day that weren't previously. And when we've looked into it, what's become apparent is we think it's the bowel prep that the patient's having to take. So they have to take, it's not very pleasant. You have to drink a load of solutions to help the bowels move. We actually changed, there's a national standard bowel prep that's been mandated on organisations, and we think that just some of the reactions to some patients meant that they weren't following it appropriately or had some adverse reactions. So we're closely monitoring that. As I said, small volumes of patients, but it is something just to be aware of. Next slide, please. Okay, so this is essentially a list of, I wouldn't say this is exhaustive, but these are some of the kind of more high-profile things that we're doing to support bringing down the waits for our patients. So the first thing is a CDC, that's a Community Diagnostic Centre. So our first one opened just a few months ago in July in Halifax in Broad Street. So I'm conscious that is in Halifax, but it does benefit our Kirklees patients as well. The CDC in Halifax is about to go to 5 days a week, so with those additional clinics, additional capacity, that will come online for Kirklees patients as well. So we're also, we've also got a second community diagnostic centre that's been built in Huddersfield. Construction has started, and that will open, the plan is that it opens at the end of 2025. We've got, from a theatre point of view, we do a lot of work around our theatre improvement, our theatre productivity. So we have a ring-fenced ward at Huddersfield Royal Infirmary. So what I mean by that, that's a ward. Now, this is actually one of the silver linings that came out of COVID, where we had to keep our surgical patients very different from the rest of the wards, and we've been able to carry that on. So whereas before, if we had a lot of patients waiting in ED and we needed to admit them, we would run out of beds. So we would have to cancel a lot of our elective procedures at the height of winter. What we've been able to do is to keep this ward strictly for elective patients only. And at times it's been tricky, you know, when you've got loads of patients in ED who need to come in and we don't have a bed. So it's always a balance. But for the last couple of years, we've managed not to cancel any patients as a result of not having a bed. So that's great, and that's helped improve our throughput from an elective point of view. GIRFT, so another, we love our acronyms. So GIRFT is Getting It Right First Time. So that's a national programme that NHS England lead, and it's the concept is this is clinical leadership leading improvement across hospitals. So rather than managers like Kitty and myself, this is clinicians working with other clinicians to try and drive improvements. And yeah, we've got our first robot that's been going, I think it's about 15 months now. So we've in colorectal and urology and gynae. So there's been some good good outcomes there for patients who are waiting shorter time in hospital. And CPC, another acronym, apologies. So this is cost per case. So this is something that we've trialled at the weekend. So coming out of COVID, like many other trusts across the country, like all trusts rather, we had a deficit of theatre capacity. We'd lost a lot of people who had retired maybe or just moved on. So we were running below our baseline level of theatres, and we were really keen to try and get some additional capacity to make up for the shortfall. And so what we did was we've set up a system where we run weekend lists, and the staff, so the surgeon, the anaesthetist and the theatre team, rather than being paid on a fixed time hourly rate, we pay them on how many patients they're seeing. So that's the same model that's in the independent sector, and I've certainly had dozens and dozens of conversations with surgeons that have said, Tom, if only you could pay me like I'm in the independent sector, we'd have so much more throughput. So we've tested that, and it's worked well. I would describe that as a marginal gain rather than a silver bullet, but all these things together help. Super clinics. So we've been running super clinics in gynecology, ENT and cardiology. So what's a super clinic? So it's a concept, again, that GIRFT have keen to promote. So the concept is, rather than having a single doctor, a single consultant who sees his or her patients, who might see 12 patients, 16 patients over the course of 4 hours, you have multiple doctors, maybe consultants and registrars, but also there you have pre-assessment. So if you're a patient, you go and see the consultant. The consultant says, we'd like to operate on you, rather than having to come back 2-3 weeks later for your pre-assessment. The pre-assessment is there and then, so you go see the consultant, go see the pre-assessment, and then when you come back, we'll give you a date in 3 weeks or something. So it's much better from a patient experience point of view, but also from a throughput point of view. We're able to scale it up, and we're able to see more patients than we would just running those individual, quite traditional clinics. So that's something that we're really rolling out in these specialties and looking to do likewise. Data quality, top 10 trust for LUNA, robust tracking. This is a bit management speak, isn't it? But what LUNA is, what's this saying? LUNA is this national body that assesses how the data quality of NHS trusts. So we've got a good mark. What does that mean? It means the quality of our data is good, and so that enables us to manage patients through their pathways. When we look at the thousands of patients that we have, we can be confident that those patients are real patients, that they are at the right stage of their pathway, that we're able to then manage them appropriately, rather than them having been discharged, or maybe they don't need their operation anymore, and so it makes us more efficient. And I would say it's one of the key enablers, this informatics support, and the team that we have, they're really amazing and help us to do our jobs. Another thing about use of insourcing. So again, it's what's, and apologies, you might know, but insourcing, that involves where outside organisations, private organisations, they're using NHS staff, but they effectively bring these teams in onto your site. So they might use your theatres, your outpatient clinics, but they are responsible for paying the staff. And we had to use them a lot coming out of the pandemic. I'm glad to say that we've been able to reduce them a lot, and it's just ENT where we're using them because we've got significant pressures there. But it's very much our intention. We want to repatriate all that work and do it in-house wherever we can. Demand management includes the A&G. A&G is advice and guidance, so this is where we get referrals from primary care, from colleagues, from GPs, and rather than bringing the patient in to a clinic in secondary care, we're able to go back to primary care and give them some advice to pass on to the patient. So we're again keen to support that. We're talking about pathway changes to support endoscopy. So this is something like, I've had an endoscopy, I find it's particularly unpleasant, and there's something that we're using called cytosponge. So rather than having the scope go all the way down your neck, it's a little sponge that goes down on a string, and it'll go down and it will pick up other things down various tracks, and then it comes out. So it's far less invasive, far less uncomfortable for the patient, and far more cost effective as well. So there's some stuff there that we're really excited about rolling out further. AI is very, very salient. So we're using some of this in, for example, our lung X-ray. So what happens here is, in effect, we're double reporting. So AI will be used to begin with to risk stratify lung X-rays into ones that we think are over, that high likelihood that they will be okay. So they get streamed off to be seen as routines within 2 weeks. But then what AI does is also it risk stratifies those that they think are more serious, and they're seen within 48 hours. So that's something that's that's helping speed up those pathways as well. And then just lastly, patient engagement portal. So this is trying to improve our communication with patients. So this is effectively a digital interface that through which how we're going to start communicating with our patients. So at the minute it's limited. We're just rolling it out. It's obviously quite a big endeavour. We are messaging patients just to double check. Do they still need their procedure? Have they been treated elsewhere? Maybe their symptoms have gone away, they don't need it. So that's helping us to triage some of the patients and save our capacity. The plan is then to go further, though, and to increase the functionality of the system so that patients themselves can book their own appointments at a time that's, you get an appointment at 3:40 and you've got a job. It's not the most convenient at times, is it? So we're trying to improve that and make it a bit more patient-centric. I am conscious of the conversation we had earlier about maybe patient groups that aren't as digitally literate as others. So this isn't a replacement. This is in parallel to the traditional letters and phones. So yeah, I think that's everything for me. So I'll hand over to Keely.
Thank you, Tom. Next slide, please. I won't go through everything because a lot of it's repetitive from CHFT, but and certainly for Mid Yorkshire, we're really proud to be 10th in the country against 135 acute trusts for our diagnostic waiting times. We were 3rd only about a couple of months ago, so we've slipped that slightly, but our latest August performance is 98.6%, which is excellent. In terms of waiting list management, though, a slightly bigger challenge in comparison to our partners at CHFT. Although we are planning to eliminate all our 52-week waits by the end of the financial year in March, we have 2,300 patients to treat by that point. But it is coming down month on month. We do have some legacy 65-week waiting patients from the target in September. I think we ended September at 62 patients in our very challenged specialties, which is in the pack in gynecology. I'm really pleased to say ENT only had 2 patients that breached that standard, and that was because of sickness of one of our surgeons. So considering where ENT has been in Mid Yorkshire, I think that's a real celebration. In terms of cancelled elective and planned procedures, we've just invested in a new theatre system that's called Aqua. We've got much better data coming out of that system now, which is supporting our theatre improvement productivity group. We've implemented a standby patients when patients are not fit or don't turn up on the day in DNA. We've got another patient waiting in the wings there to come in, so that's proven really good in terms of our productivity. Moving on to the next slide, please. Again, our initiative's not exhaustive, so I won't go through all of them, but we have had our community diagnostic centre there since March 24, seeing over 27,000 patients in that unit. That unit's in Wakefield. So that does support easy access for our patients, enhancing the pathways and improving the capacity. Our elective surgical hub, as Tom described, these ring-fenced hubs where we can get through a lot of elective surgery. That is due to open in January 25, and that's at Dewsbury. So that provides 2 new theatres, 4 major treatment rooms and 10 outpatient clinics. We're expecting to do over 50,000 patients per year there. Again, theatre utilisation, we're lucky enough, we bought our 2nd robot this year, and that we placed that deliberately in Dewsbury Hospital. We've got one in Pinterfields Hospital, so now we can offer robotic surgery on both of our major sites. So that's quite an improvement for our robotic programme, and we we do want to increase it to a 3rd robot next year. That's our hope. We're going through the process at the moment, very similar to the elective hub, but an orthopaedic hub. So that's going to be placed in Pontefract Hospital. It's there now. That way we have a centre of excellence of orthopaedics, centralising all our orthopaedic surgery to one site. Orthopaedics have a ring-fence ward, so we used to have 2 wards across. We had one in Dewsbury, we had one in Pontefract, and we had a 3rd in Pinderfields. Now we've centralised that. There's one in Pinderfields for acute surgery, and there's one in Pontefract. So that unit, 2.5 session days, Monday to Friday, and 7-day workings. We operate 4 lists every Saturday and every Sunday for orthopaedics. Patients can have their outpatient appointment across any of our sites, but the surgery is centralised. Again, like Tom, super clinics in gynecology, ENT, neurology, they are our most pressured services. The data quality, Tom's already described for me, thank you very much. We do use some insourcing to increase capacity. That's in ENT for us. Again, we all feel the ENT pain across the patch. And we do advice and guidance in Mid-Yorkshire. So we get about 4,500 referrals a month, but thankfully about 80% is that our diversion rates don't come to clinic. So that's really good, helps to manage our patients and keep them at home with the right advice and guidance from the professionals. Again, pathway changes, so speeding up pathways for lower GI in particular, so do straight to test. It saves patients coming to see a medical professional to say you need to go and have an endoscopy, but don't do that any longer. You go straight for your test. And we've got the Patient Knows Best portal, very similar to what Tom described. It's how we communicate with our patients and they can get all their test results, so on and so forth, through these apps, which is found to be really good. So I think that's it from us, but happy to take questions.
Thank you. One of the questions I actually wanted to ask was for Mid-Yorks, where is the community diagnostic hub based?
I have been. I'm not very local to Wakefield, but it's it's opposite Wicks. I remember that. Yes. And next.
Bottom of Wakefield, Westgate, in I think it used to be a carpet shop.
Are there actually any plans to offer a diagnostic centre in Dewsbury or sort of Batley Way? Because I'm always very mindful that with the rundown of sort of the services being taken out of Dewsbury District Hospital and then going to to Pinderfields, is people have got to travel there, or is obviously there is a diagnostic unit in Huddersfield, or there will be when the university's there. Is that going to be able for, say, patients from Dewsbury that are under Mid-Yorks, could they come there instead of, say, having to go to Wakefield, say if they lived in Murfield or somewhere?
Hi, I'm not aware of a further diagnostic hub being developed on behalf of Mid-Yorkshire. I think you make a good point, and we do have a board, a shared board between CHFT and Mid-Yorkshire, and it may be possible. We can certainly have a discussion around that, about that transfer of patients between the hubs, because I don't think it should matter which trust you get referred to, it's where you get your diagnostics. So you make a good point. Thank you.
Yeah, thank you. I think it's something that we looked into. I think when your board had first started to look at where the right locations might be, is a defined range of procedures, I think, that are offered through community diagnostic centres, and some of those procedures are similar to some of the ones that we offer in general practice as well. So I think the specifications around the type of building, even when it's down to sort of like floor strength to take some of the equipment. So actually, I think we did look, and I don't think there's a suitable location as it stands within Dewsbury, but there is a good range of procedures, similar procedures on offer in general practice. But I think it's the right question to ask around accessibility. I think when the whole programme comes to fruition and we've got something that's based on the university campus, we've obviously got some temporary provision, I think, up at HRI now, and then obviously the one in Wakefield. It's a reasonable spread. I know there's not going to be one at the end of every road, so there's always going to be some travel requirements, but it was felt like that would be a reasonably good geographical spread for the patch for all of our population.
Thank you. Have the panel got any questions? Councillor Monroe.
Thank you. This is a question Mid-Yorkshire. It's about the page 121, the consultant workforce gaps. I wonder if you could tell us why or what the root cause of the vacancies is. And then my second question is, what is being done to fill those vacant consultant posts? Thanks.
Thank you. Yes, in terms of the challenges in the consultant workforce gaps, these aren't really just for Mid-Yorkshire, it's quite widespread across the NHS. ENT in particular, right across West Yorkshire, we have a lack of ENT consultants. Obviously, we both feel the pain in that, but as does most other organisations in West Yorkshire, hence why we have to insource a lot of ENT capacity. In terms of ophthalmology, again, it's not only for Mid-Yorkshire, glaucoma consultants across the NHS, but they are really lacking. We have our last glaucoma consultant has just retired at the end of September. So at the moment we are very, very much reliant on Leeds and Bradford to support our glaucoma patients. We are out to recruitment and we do have an interview scheduled in the next 2 weeks, and we're very hopeful that we have got a consultant from Boston, Lancashire, not Massachusetts, hopefully coming to Mid-Yorkshire. That would be a real scoop for us. In terms of gynaecology, it's not gynaecology in general, it's gynaecology subspecialty. So Mid-Yorkshire is the centre of excellence for endometriosis. We are the regional service. We struggle with that capacity, we struggle to recruit surgeons to that, and then also for urogynecology. But in terms of general gynecology, we're okay. Anaesthetics, I think we've been hit particularly hard in Mid-Yorkshire. We've had a lot of retirees. We had a very aging anaesthetic workforce. So in terms of that in particular, we're going to overseas recruitment. We did that last year. Went to India. We got 3 consultants from India last year. We're going back out there again. And we have only recently recruited 7 local trainees into Mid-Yorkshire who start in February when they post the CCT. Unfortunately, we've also lost that equivalent in retirements. So it's sort of a status quo at the moment. But it's really difficult, consultant recruitment at the moment. We're looking at, obviously, different roles, not in terms of associates or AHPs, but certainly in terms of specialist doctors who can't get on the specialist register, but they are specialists in their own right in anaesthetics who can therefore do these procedures. But it's not easy.
So thank you for that. So is the problem then is it that people or in the medical profession aren't training for those specialists roles, ENT, whatever you've described, gynecology, endometriosis? Is that the problem, or is it that they've gone to other countries?
I think if you listen to the news, it's probably a bit of both, because a lot of our doctors in our country have gone to Australia. They do great packages. You get a home package, you get thousands of pounds to do so. But some of this is historic. It's kind of what governments did 10 years ago and how many college places they put and for each specialty and subspecialty.
If I could just reiterate...
I was sorry to interrupt. I was just going to add, just in terms of mitigation, so Keely and I meet every Thursday along with Leeds, Bradford, Harrogate and Airedale, and it's been going probably a couple of years now, 18 months, and there we will call out if we've got gaps like Keely's describing and that's impacting on some of our capacity and we've got long waiters, we'll help each other out through mutual aid. So it is something that we do. It doesn't outsource the issue, but it does help to alleviate some of the pressure that the patients find. Yeah.
As somebody that's worked in ophthalmology for some time, you will find that there has been the crisis in glaucoma consultants is a national thing. It is not just Mid-Yorks, it's not just CHFT, it is a national thing. When they start off with their training, they're not sort of automatically put on a pathway. It maybe was, oh yeah, I actually like this, I want to do more in that sort of thing there, and that's where the problem occurs, as it does with sort of other subspecialties seem to come and go, and then sort of more doctors go into that part of it basically, but it isn't just Mid-Yorks. Helen?
Just a quickie, really. Generally, the trend seems to be that there's a lot of work happening, and the waiting times are down, and there's action on sort of all the other things that. Do you generally feel optimistic? I know it's a very wide thing. I mean, are you generally speaking optimistic, or are you kind of thinking, no, I'm worried? There's something going on that I'm really worried about. Be honest.
Put us on the spot. Are you talking about in terms of elective waits for patients? Is it that specifically?
It was a general question about what you've presented.
Yeah.
That there looks to be some really, really good news.
Yeah.
But what is it that's really worrying you?
Yeah, so I think I would definitely be glass half full. I think we've seen, hopefully in the way we've described, we were a few years ago, 104-week waits, 2-year waits. We're nowhere near that, so we've done a lot. I think that some of the scars from the pandemic are healing now. So some of our teams, especially teams, I mentioned in terms of theatres and theatres, because they had airway trainings, they were pulled out of theatres to go on to COVID wards, respiratory wards. So that's what led to less theatres running. But then also, I think there's a lot of PTSD, if we're honest with you, and they left. So, but I think I'll talk for both of us. We've been able to recover that position. So we're back up to full capacity in terms of our theatres. Now, clearly, we need to be at full capacity plus to get these waiting times down. So, but I'm certainly positive. I think if you were to push me about what I'm most concerned about is ENT, in the way that Kirklees described. So we have 5,500 patients, which are called ASI, so appointment slot issues. That's basically language for referrals from primary care that we haven't got the capacity to give them an appointment. And like Kirklees, that's because we're suffering that lack of, I think off the record, but we've got some dynamics, some HR issues going, and I think we found it far to recruit. Glass half full though, we've just appointed someone, and our recruitment is getting to a better place. So even on ENT, if I was here a year ago, I'd be more sceptical, but I feel like we've got a plan to tackle that.
Can you just paint me a picture of what that actually means for somebody who's waiting for that appointment? Because ENT is a big thing.
Yeah.
Well, I don't actually know what that means for a patient.
So what it means? So if you go to your GP and your GP says, right, you've got some ear blockages that I think I'd like a specialist to see. So an ENT consultant, the GP will refer in to CHFT. Normally we would. For all other specialties, we've set a standard this year that you will be seen in clinic no longer than 18 weeks. For ENT, you're waiting 44 weeks. So it's a huge differential. So that means, obviously, that's a long wait, more than, it's 9-10 months, isn't it? You're obviously living with a condition. Hopefully it's not debilitating, but it might be. There's always an element of patient safety risk with that as well.
Presumably deterioration as well of the condition.
Exactly. And I think a big push that we didn't talk about is there are certain patient groups whose the impact on them of that way is far more pronounced. I'm talking about learning disability patients who have a low life expectancy. So a 44-week for them is way higher than a normal non-learning disability patient.
So is this where do you bring into action the process of priority, health-wise, and then date-wise? Yeah.
So for all our learning disability patients, we prioritise them. So they get access. I think it's the same for Mid-Yorks as well. And interestingly, recently, NHS England, I think you'll see it increasingly in the media, there's a focus on paediatrics, on children now, because we have seen a divergence that adults are being seen quicker than children. And again, back to an impact on my daughter had grommets put in, and she had something. It was transformational in terms of her being able to hear at school. But that was, another kids that can't really hear, they can't learn, then maybe the teachers get frustrated. That's an issue we're having to work through. So that is something that we're doing as well. I think, there's no easy solutions to that because it all comes back to capacity.
And that capacity, that capacity is about staffing, recruitment.
It's predominantly the rate limiting factor is the medical resource, so be it consultant or registrar. So that when it comes to capacity, it might be theatres sometimes, but I think we're okay, touch wood. But it's the doctors to see the patients in clinic. That is the rate limiting factor.
So in terms of what's in your control and out of your... So there is a national shortage. There is a lack of training. So doctors being in ENT training at medical school, so that is an issue. What can we do? So, you can try and make yourself as an attractive place as possible to attract what is you're fighting for resource, aren't you? We have struggled with that. I think I've alluded to some kind of personal issues, and we're coming out of that. So we are being able to attract people now, which is super positive. So I think it's not that we just say this, we're doomed. There is stuff we can do. It's just can be quite challenging. Okay, thank you. I appreciate your response.
Yeah.
I'll hold you to it. Everything's perfect except.
Are there any further questions from the panel?
Just a quick one. It's quite a positive picture. I think you've painted. I think things are going in the right way. I'm excited to see the new CDC open. I've heard good things about the Wakefield one from patients that have used it. They're absolutely thrilled. Does the CDC have much draw on your? You've got staffing issues already. How do you staff a CDC? Is that a big problem?
I think we can do a bit of a double act, but it's a different kind of staff. There aren't consultants in CDCs. I think that's probably the most rate limiting factor. Of course, they're professionals, but they're easier to recruit. They're easier to retain. A lot of in our CDC at Wakefield we do phlebotomy services. We have lots of phlebotomists. So it's not taking staff away from the main site. It is a recruitment, and they've recruited to those posts quite successfully.
Yeah, and I think historically the pressure when it comes to diagnostics has been the lack of capital investment. So MRIs tend to be a rare commodity, and that's largely because of the lack of the MRI facilities. I think you're seeing a lot of reporting on this in the press now in terms of, I think, austerity. There was the investment for capital facilities went down, and so there is a gap. But I think the CDCs are great because they came with some capital investments. I think they've been a real positive boon in the way that Kirklees described. We've been able to staff them as well.
Thank you. Keep up the good work. It's looking good, I think. Thank you.
Is there any further comments or questions? Can I just thank everybody for coming today and giving a comprehensive report to us all and answering our questions. Thank you. We'll just move on to the work programme. It will be quick. This bit will be really quick, just on the work plan. Is on our next meeting, we're going to be looking at services provided from hospital to home in Kirklees, and looking sort of how quickly people can get all the things like physios, OT coming into them there, and we should hopefully be given not a briefing of the Kirklees CQC inspection there. It's not happened as yet. Is also going into, sorry? No, it hasn't been done. It hasn't been done as yet. It was looking at sort of basically a briefing of what they're doing to prepare for the actual inspection there. Is in January there will be an informal meeting which will be online, which is going to be a joint children's scrutiny and our committee there, looking at sort of the uptake of vaccinations. You will have had the invite for that. Is also regarding the referral that we did to the JOSC for the maternity services. I will be at the JOSC meeting in Coldale, and it is an item on the agenda, so at the next committee I'll just give you a little informal briefing before we start the meeting. Is there any questions?
Just a quick I did wonder when the previously were here, and I should have perhaps asked, one of the issues around dentistry was access to theatres, and that from what they were saying, it feels like there's more capacity in theatres, and I wasn't sure when we're looking at dentistry again.
We're actually looking at dentistry again in January the 22nd. It's coming back up there. We gave them a slightly wider brief, not just for the surgical one, because I felt last time they came there was more unanswered questions. They were quite happy to tell us a certain percentage of children had accessed a dentist, but what I wanted to know was that a routine or was that emergency? And they couldn't sort of tell us that kind of thing.
And I think in fairness it might have been due to the previous sort of reporting that they'd given and our subsequent questions. So I wonder if it's, yeah, you're right, I think, to say they would widen that a little bit.
And I've just been told that the Children's Scrutiny panel will be joining us for that one as well. Yeah, for the children. Any further questions? I'll close the meeting.